Good afternoon, respected judges and the audience. My topic for today is targeted laser photocoagulation of capillary macroaneurysms with TRIM in diabetic macular edema. It's not moving. Yeah. The topic for presentation is targeted laser photocoagulation of capillary macroaneurysms with TRIM in diabetic macular edema.
Reset the time, please.
The topic for my topic is targeted laser photocoagulation of capillary macroaneurysms with TRIM in diabetic macular edema. We know that microaneurysms are the earliest clinical finding in diabetic retinopathy, and the leaky microaneurysms contribute to diabetic macular edema. Microaneurysms are typically smaller, but aneurysms which are arising from the capillaries but larger than the normal microaneurysms are described in literature with various terminologies such as telangiectatic capillaries, retinal capillary macroaneurysm, and it is documented that they are better visible on indocyanine green angiography and infrared reflectance image, which is not easily available with most of the clinicians. So in this presentation, I will be describing a clinical way of identifying a capillary macroaneurysm. That is, here we can see that an aneurysm surrounding which there is a wide trim, and in OCT we can see that it is composed of a hyperreflective rim with a hyporeflective lumen, which confirms the presence of an aneurysm. In a retrospective data, we identified that the diabetic macular edema due to these capillary macroaneurysms with TRIM respond poorly to anti-VEGF therapy. So the purpose of this study is to assess the efficacy of targeted laser photocoagulation in the management of diabetic macular edema secondary to the capillary aneurysms with TRIM. This was a retrospective study in which we included diabetic macular edema in which the cases had capillary aneurysms with TRIM within the edematous area, included both the treatment naive eyes and eyes with poor response to intravitreal therapy. So capillary aneurysms with TRIM were identified by a good clinical examination with slit lamp biomicroscopy. It was documented on color fundus photograph and reconfirmed on optical coherence tomography. A 532 nanometer double frequency Nd:YAG laser was used. The spot size varied from 50 to 100 micron based on the size of the aneurysm. The endpoint was the complete blanching of aneurysm. They were followed up every 4 weeks until the resolution of edema and every 3 monthly after the resolution of edema. So we included 10 eyes. I will just describe each case. We can see that in this case 1, the patient responded poorly to multiple doses of anti-VEGF bevacizumab, and here we can see that there is an aneurysm with a wide trim. And post-laser, after 2 months, we can see that it is completely sclerosed, and we can see that it's completely obliterated on OCT, which is in the form of a uniform hyperreflectivity. And we can see that the macular edema had completely resolved, and there was no recurrence for the last follow-up till 6 months. Case number 2, the patient was initially treated with multiple doses of bevacizumab and dexamethasone implant with no response. Here we can see that there is an aneurysm with a rim. 2 months post-laser, we could see that the cavity was completely obliterated and there was a complete normalization of the foveal contour, and there was no recurrence till the last follow-up at 24 months. This is the other eye of the same patient. In this eye, we considered laser as a primary therapy considering the success with the other eye. So here we can see that there is a complete obliteration of the lumen and a normalization of the foveal contour. He had a recurrence at 18 months due to development of a newer capillary aneurysm with a rim. Case number 4, laser therapy was considered as a primary therapy. Here we can see the capillary aneurysm with a wide trim. Post-laser, 2 months, we hardly see an aneurysm. We can see that it's completely obliterated on OCT and the macular edema has completely resolved compared to the initial. And there was no recurrence till 6 months follow-up. Case number 5, again a similar case in which we can say that there is a complete obliteration of the aneurysm. There is a complete resolution of macular edema and obliteration of aneurysm. Here we can see that this is the post-laser 1 month, there is a complete resolution of macular edema and no recurrence till 4 months follow-up. Case number 6, a similar response, complete obliteration of the aneurysm and a normalization of foveal contour. Case number 7, here we can see that there is an obliteration of the aneurysm, but the subretinal fluid has resolved, but there was a persistent of intraretinal cystoid space. So case number 8, here we can see that one of the aneurysm is completely occluded, but the other aneurysm still shows a cavity. There was a partial response. Case number 9, there was no improvement in macular edema in spite of a complete obliteration of the aneurysm. Case number 10, here we can see that there is an aneurysm over here with a surrounding intraretinal hemorrhage. Post laser, the hemorrhage actually increased, but there was no change in the macular edema. Rather, there was a minimal increase by 3 months of follow-up. So out of the 10 eyes, we could see a complete resolution of macular edema and a long-lasting resolution in 6 cases, and a partial resolution in 2 cases and no improvement in 2 cases. Aneurysm could be completely obliterated in 9 eyes. So the limitations of the study are its retrospective, small sample size, variable follow-up duration, and long-term risks are not assessed. To summarize, capillary aneurysms with TRIM are seen in diabetic macular edema. It may be associated with poor response to intravitreal pharmacotherapy. It can be identified by a good slit lamp biomicroscopic examination and confirmed on optical coherence tomography. Targeted laser photocoagulation results in good response in good proportion of cases. So it should be identified, and a laser photocoagulation should be considered in such eyes. Thank you.
Thank you, Dr. Pradeep, for your presentation and study. Dr. Meena would like to comment.
Thanks for the good presentation.
A good presentation. You have put together the cases quite well, but do you feel that so much thickening of the retina could be because of this unifocal single lesion that you see? And did you combine your targeted laser photocoagulation with anti-VEGF injection?
No, ma'am. All these cases are single monotherapy, sir. Monotherapy with laser. It was not combined with any anti-VEGF or any steroids.
So you personally feel that that single lesion has leaked so much and caused so much retinal thickness?
Based on the observation, it looks so. But the major thing is we came up with this plan mainly because of our results of a previous retrospective study in which we noted that these aneurysms were seen in close to 12% of cases in diabetic macular edema, and they responded quite poorly to anti-VEGF therapy. Here we can see 2 cases here in which there was no response, absolutely no response to anti-VEGF therapy. Based on that observation, we considered laser as a primary therapy in such cases, and only the aneurysm was lasered, ma'am.
So your take-home message is that if you see a rim aneurysm, you treat it only
Yes.
with laser.
Yeah, just one question. Very good study. It's well documented, already known that these are the ones which cause the non-response. My question is that, though again, the gold standard of identifying these microaneurysms are by doing ICG. Because these are fibrin-filled microaneurysms which are picked up more on ICG. You picked up on a clinical picture, that red color with a white rim. How many of, because you did a OCT also, how many of them had these type of ring but didn't have the clinical picture of that rim? Because it's not like all of them will present like a rim-like. Because the take-home message you are telling is, without doing ICG, pick up these by a fundus photo or a OCT. So could you see how many of, because you had both, how many of them didn't had the clinical picture of that ring-like?
Sir, in this study, actually, we have included only the eyes with rims, sir.
Okay, so that was your inclusion.
That was the inclusion criteria. We have included only the eyes with rim.
The second thing, you need not wait for 3 months for seeing the obliteration. Actually, what we do is we do it immediately so that you see that obliteration immediately after laser. You know that it has worked. It doesn't take 3 months for the obliteration to come.
So what the image, whatever we have included is at the time of resolution of edema. We have followed up every 4 weeks. We have done the OCT.
Use it to guide your treatment, because these are bunch of aneurysms.
Yes, sir.
Whether you have treated it correctly or not, immediately you can do OCT. If you have obliterated, means you have treated that.
Yes, sir. Yes, sir.
Good study.
Thank you, sir.